All right, we're ready for part 3. Here's where we really get into the details of assessment for kids who have been affected by trauma. We've already talked about what counts as trauma, so what kind of events count as exposure to a traumatic event. We've talked a little bit about what trauma's effects are on students, more in a general sense, for the brain, the body, and behavior. Now we're going to talk about this kid sitting in front of you right now. How do you determine whether they have been affected by trauma? How do you gather that data? So, we talked this morning about how SAMHSA defines trauma as including 3 components: the event itself, how the child experienced the event, and then the effect it had on them. In assessment, you can think of this as we need to assess 3 things. We need to assess exposure, the event, their actual trauma symptoms or potential symptoms that may be related to post-traumatic stress. Notice I left the word disorder off of there. PTS without the D is a totally acceptable term to use in a school. Post-traumatic stress. Stop. And then last, impact. So when we are looking, for example, for eligibility for special education, we not only have to determine, whether they have a disability condition or not, which we'll get more into in part 4, and we'll a little bit dive into right now with the emotional symptoms and the physiological, but we also have to determine whether it's impacting them at school through learning, development, behavior, educational attainment. So we do have to assess all 3 of these things when we have a child that's referred to us who is suspected of having been exposed to trauma and possibly being traumatized. So let's actually go backwards. We're going to start with impact, I think. 2 reasons. 1, this is what you're most used to seeing already, the kinds of data that you may already have collected. And 2, this is usually why the kid has come to your attention anyway. So they may not come to you for trauma exposure or symptoms. You may not have data on that yet, but you may have data on the impact. How do we do this, by the way, right? We're not just winging it. We're going to do the same type of evaluation we normally would do. We're going to include RIOT. Anyone know the RIOT model? That's right. R stands for records. We're going to go back and review their records. School records, discipline records, any outside records. We're going to interview. I for interview. Interview is the most underutilized form of assessment, probably in child development, especially in the schools, and especially for emotional disturbance. We're going to observe the child. We're going to get other people's observations of the child. And last but not least, we may do some testing. So let's look at RIOT in terms of impact. What are we looking for? Well, just like we talked about this morning, my guess is that this child has probably come to you for behavioral things. That's typically where we see trauma kind of rearing its ugly head, is usually they're first referred for behavior. Remember that kids are overrepresented usually in these emotional behavioral disorder categories. So while psychiatric disorders may not be known, they might have an outside diagnosis, but I'm more looking at if I already gave a BASC, or I'm already hearing teachers' reports that they're having poor social skills, externalizing problems, they're acting out in the classroom, and then the big source of data for you might be, or the first thing that you look for, their discipline referrals and suspensions, so their discipline data. And that's usually fairly accessible for you to find in your system, whatever you use at your school. And you can look up, what's their discipline history like? What's it like compared to other students in their age and grade level? And we can try to figure out impact first. I know it seems backwards, but is this kid even having trouble at school? In Tennessee, we used to hear a lot that, well, the kid's grades are fine, so we're not going to evaluate. I kind of see why people say that, right? So academics is usually what we look at for special education first, but remember that behavioral performance is also a school-related outcome. That means that some kind of disability condition may be affecting a child. And so there are plenty of court cases showing that behavioral or emotional data should be considered as well as part of special education. Their behavioral progress in terms of things like social skills, pro-social behaviors, peer relations are all part of school-related outcomes. So we're looking at all this data that we already have. Of course, we're also going to look at academic outcomes. Some kids may come to you first because of these kinds of things. And usually they're pretty highly correlated, right? Like, so you usually don't have a kid who's acting out in class all the time, but their grades are perfect. Unless they're, in GT or something like that, which is a whole nother topic. But a lot of these kids are behind academically as well. So you may have seen them in early childhood settings, pre-K. They may have delayed language and adaptive skills, so kids who are referred for developmental delays or non-categorical early childhood. You may see their grades. You want to look at state standardized test scores, but also what's not on here is you want to look for, of course, the teacher's report, work samples, how are they doing in class? Like, does the teacher feel like they're catching on at the same rate as other kids? And hopefully you might have some RTI data, or MTSS, I guess we're calling it now, data about that child. And maybe their response to intervention, hopefully. You also want to look at things like absences and whether or not they've been retained. This might also reflect in cognitive scores. So of course, we're not going to use cognitive scores to diagnose anything in terms of emotional behavioral disorders, but be aware, like from this morning, that research does show that many children, at least those who have been maltreated, abused, or neglected, do have lower, verbal IQ, performance IQ, or processing speed, poor executive functioning. These things are all, I wouldn't say red flags, maybe they're orange flags, like something is going on. The nice thing is that you already have all this data, hopefully, because you're doing a comprehensive evaluation. So you are looking at these impact data. You're looking at their academic, their cognitive, and their behavioral functioning. And again, we're looking at that first because the kid comes to you first for that probably, and because they're not going to qualify anyway if they don't have any impact on any of these things. So why go down the rest of the list when you're not seeing any of this yet? Okay, those are the things you probably already know how to do. Those are the data that you already have. My guess is that you do not have data yet on exposure or symptoms for trauma in measures that you already give, or observations or interviews that you're already doing. Records possibly have some evidence of exposure. So you might look through records. Some example events other than those we've already talked about is looking for some, invasive medical procedures. And being that we are close to the Texas Children's Hospital and the biggest medical center in the world, it wouldn't be unheard of for you to have kids have really serious medical problems, really serious series of surgeries and things of that nature that may have been very terrifying to them. I mean, think about kids who are undergoing cancer treatment or something like that, or kids who are going through major medical procedures and don't understand what's going on, like they're 5 years old and they have no idea. That could be traumatic depending on the criteria that we talked about this morning. Car accidents, really common. Animal attacks, kids that have been bitten in the face by a dog, these things that you see on the news, that could potentially be traumatic. This isn't an automatic discount, right? We talked about it earlier. You're going to have to look at a lot more details than just knowing that it happened, but we do want to be aware. War and genocide, if they're from another country. Natural disasters, we have plenty of those here. So maybe Harvey, maybe they moved from California where there's earthquakes. Maybe they moved from another country where there's tsunamis. These things are all possible. We always want to look at the records to see what possibly could have been disrupting this child's development, learning, and behavior. Sexual violence. Remember that in teenagers, this doesn't have to be sexual abuse. Could be something like sexual assault, sexual harassment from maybe a teacher or a peer. And it could also be date rape, which is increasingly common in increasingly younger ages. Of course, maltreatment, abuse, and neglect we've talked a lot about. That definitely counts. You may have records of this. You may have a strong suspicion. My advice is to stick to things that are already recorded, because our job during this evaluation is not to go digging around and be a CPS investigator. We just want to know how these things may have affected their learning, development, and behavior. But if it's there, it's there. Sometimes kids who are in foster care will have some of their records available to you if you ask their social worker. Most kids or all kids in foster care have to have an assigned social worker through DFPS. And if you can get in contact with that person during the evaluation, which you really should, they will have hopefully some records for you, or at least some information that they can share. They don't always share all that information for good reason, right? We don't want it to get out for just gossip purposes. But you do have a need to know for some of these educational purposes. So my other advice to you would be to kind of get in good with that DFPS worker if you have a kid who's a ward of the state or who's in foster care. Community and school violence. So this is coming up more and more lately. We had the shooting in Santa Fe, which has affected some of us here in Clear Lake pretty personally. But we've been dealing a lot with this, and you'll see some people at Texas Children's actually helped develop some of the measures that we're going to talk about in a minute. And they're also the people that are involved in some of these community and school violence efforts after the Santa Fe shooting and after Hurricane Harvey as well. They also do a lot of work at Texas Children's related to immigration trauma. So deportation, all of those, isolation. And then COVID, of course, we have to add. This was not on the ptsdva.gov website, of course, yet, but there are some things related to COVID that could potentially be traumatic. And you'll see we have a special measure for that I'll show you in just a minute. So those are the things you're looking for in records or interviews regarding exposure. You're also going to look at symptoms. Again, records. So these would be records of either DFPS, medical records, counseling notes, something saying like they actually have had some of the symptoms that we're going to talk about in a minute of potentially traumatic impact. So let's talk about the symptoms. Now, we're not diagnosing PTSD in the schools, but what we know about the effect trauma has on kids is from PTSD research again. So we are going to use these symptom categories as a guideline. When you think of post-traumatic stress, D or no D, there's 4 symptom categories that research shows are usually pretty common among kids who have been exposed to trauma. One is intrusion or re-experiencing. Avoidance is the next one. Negative alterations in cognitions and mood, or alterations in arousal and reactivity. So let's look at each one of those. Intrusion and re-experiencing. So these criteria, by the way, are from the DSM for PTSD, and that is because this is what we're using to guide us, but kids do not have to meet criteria for PTSD in the schools. So just to reiterate that, right? The traumatic event is persistently re-experienced in the following ways. This may be what you think of when you think of PTSD, like flashbacks, all right? But when we think of war flashbacks, that's not really what kids might be experiencing. But they may have unwanted, upsetting memories intrude into their mind. They might be having nightmares. They might be having some flashbacks, like images, words, scenery in their head that they kind of can't get out of their head. It's really common for this to flash into their minds, by the way, at times when their body is still, like when they're trying to concentrate in class, or when they're trying to go to sleep, which of course then interferes with all the rest of their functioning. Really distressed after being exposed to some kind of reminder of the trauma. The trick is, like, we don't know maybe that that's a reminder until it happens. It just hits a little nervous pocket, right? It's almost like these little pockets of nerves, and you never know when you're going to hit one. But these kids may become very distressed. Maybe physical reactivity after exposure to traumatic events. Traumatic reminders. So in really young kids, like under 7, this might be reenactment through play as well. You've all seen the TV shows where they're like, show me where where he touched you on the doll and all that stuff. We're not assessing that. We're not doing that. But we are looking for really red flag things. For example, I taught preschool a long time ago. We had a little girl who would moan and say sexual things during nap time, and became very hypersexualized, we found out later, because she was being sexually abused. So that kind of reenactment, re-experiencing may occur in young children. She was only 3 or 4. Because they don't have the cognitive wherewithal yet to have maybe those intrusive thoughts or images. They're just more playing it out. The physical reactivity after exposure is more of that, like dysregulation, like startled, right? Which also relates to arousal. But maybe there's traumatic reminders and they are really, really, really having a bad day, right? A common thing we saw with this in when I worked in Tennessee with children in foster care was, for example, if they were with a foster family, and then they were having visits with their biological parents, sometimes after those visits would begin, the foster parents would report that their behavior would become unmanageable that whole week or the next day or even the day before because of kind of this re-exposure to this really destabilizing environment, and they would be really reactive and act out. Avoidance. Avoidance is a big one. Avoidance is the hallmark of all anxiety disorders, or all anxiety really. This could be avoidance, not just behavior, but avoidance of thoughts, feelings, internal experiences as well. So avoidance of trauma-related stimuli. Again, we're not sure always what the stimuli are like in a child's head. So, we have to ask them. Trauma-related thoughts or feelings they might be avoiding. They don't want to think about it. They may numb out because they're not trying to feel anything. They may claim, that they don't feel anything. They haven't really thought about it. This is all part of avoidance. And then behavioral avoidance of the people, places, and things that remind them of the traumatic event. So you see a lot of kids they don't want to go to hospitals, or they don't want to go to get in the car after they were injured in a car accident. These are all kind of forms of behavioral avoidance. Avoidance is really tricky too because avoidance is addictive. Every time we avoid something, there's a little sigh in our brains that says oh, relief, I didn't have to face that difficult thought, feeling, emotion, behavior, person, place, thing, right? And then we get this little hit of dopamine that teaches us yeah, that was good to avoid that. And that works really well in the short term to kind of addict us to that avoidance. The problem is, of course, that your life starts getting smaller and smaller because you're avoiding all these things. So there is some debate, by the way, about trauma treatment in terms of do we need to really bring up all these things again? Well, the main reason that we do exposure work and talking about the trauma is actually to target this avoidance. All right, the next one is cognitions and mood. The full title is Negative Alterations in Cognitions and Mood, and I want to point that out because the alteration piece is important. It's a change, either a worsening or starting of negative thoughts, core beliefs, affect, mood, feelings. So maybe in terms of cognition, thinking, inability to recall key features of the trauma. This is very common. For example, when women report sexual assault or rape, they often do not remember key features of the event. And there's a lot of science going on now around how we interview victims of traumatic sexual violence because of that. But the idea is that your system undergoing this trauma at the time is trying so hard to cope with what's happening, and you might be dissociating, you might be just on high CPU 100%, you're using all your resources, and so you're not really paying attention and storing a lot of these semantic details of what's happening. So that's pretty common. Overly negative thoughts and assumptions about oneself or the world. Well, we talked about this earlier, right? People are bad, they can't be trusted, bad things will happen. If anything good happens, it's temporary, but everything will eventually go back to baseline bad, which is one I see a lot. Exaggerated blame of self or others. Kids don't always think it's their fault, so I wouldn't pull a Good Will Hunting always and be it's not your fault, unless they say it is, because it could make them think, oh, maybe it is. But some kids do have this almost magical thinking that somehow they caused it, or there was this old defense mechanism from kind of Freudian times, right? The undoing mechanism of, okay, if I had been there, and if I hadn't left, then my mom would have stayed home, she wouldn't have gotten in the car, and she wouldn't have died. So this undoing, this rumination. Some of that is normal, but this is being stuck on it, right? Negative affect, so just overall poor mood. The kid is sad. He seems sad, right? Or he seems angry. Angry is really common. Irritability, which is a childhood depression sign, right? Decreased interest in activities. The key there is just like depression, it's decreased interest in activities that they otherwise would have liked. So if they didn't like math homework before and they don't now, obviously that doesn't count. But maybe they used to ride bikes, they used to paint, they used to go to Taekwondo, and they just really don't want to go anymore. They might be feeling clingy. A lot of kids during COVID are exhibiting a lot of that behavior, the clinginess, the separation anxiety, feeling isolated, so withdrawing and feeling alone. And then difficulty experiencing positive affect. So not only do they have that negative affect, but they have a hard time with the happiness and the love and the joy. Sometimes we see this in grief, for example, when they feel almost guilty if they're happy. Like, well, my mom is gone, so she, if I'm feeling happy now in my life, like, what does that say? Does that say that I don't love her, or that I don't care that she's gone, right? But it might not be that conscious, especially in young kids. It might just be, like I said, this kind of flattened affect. They're not the giggly kid anymore. They're just not laughing as much. Now, in PTSD, by the way, all of these have to persist past 1 month. Before 1 month, we call it acute stress disorder. And after, we call it PTSD. But again, like 1 month is a nice guideline, but you're not diagnosing PTSD. So I just want you to keep in mind, like, these are persistent feelings for sure. And a month is a good guideline. But if a child is exhibiting lots of these at the same time, very directly after a trauma, that is a huge red flag for at least monitoring. And I think the last one in this set is arousal and reactivity. So again, it could be hyper or hypoarousal. They could be really hyper all of a sudden or numbed out, like not reactive at all. And these are, again, changes in arousal and reactivity. Not a kid who was already jumpy and already had ADHD before and like all of a sudden, not all of a sudden, he still has it, right? This is, the kid was totally fine before, calm, very attentive, and all of a sudden they are very irritable or aggressive, which can be a high energy thing, an arousal thing. They're starting to engage in riskier destructive behavior or maybe sensation seeking, like drugs, alcohol, jumping off tall things, unprotected sex, just to feel something, right? Because their SRS has dampened their ability to feel strong emotions. Hypervigilance, always looking out for danger all the time, that threat system on alert, the startle reaction, real quick, right? Difficulty concentrating in class. So again, this may be due not to necessarily a learning disability or ADHD, but maybe it's because they're always looking out for danger and their system just cannot get into that soothing or that drive mode because they're in threat detection mode. And then difficulty sleeping, huge, 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 very common. For everyone with anxiety, right? But especially for kids and teens who have been exposed to potentially traumatic events, difficulty sleeping is a huge one. Why? Partly because what I said earlier, you lay down at night and it might be the first time that your body is still and your mind is still. And something pops up inside you and says, hey, you remember that horrible thing? Let's review. Let's put it on a loop. Difficulty sleeping is really problematic. All right, just a note, like I said earlier, 6 and under, this is from the PTSD criteria itself, but it is from research on how these symptoms differ across age groups. So for young, like preschool age kids, kindergarten, the memories they're having of the traumatic event may not necessarily appear distressing to them. It may not make sense to them why that should be disturbing, or they may just like my little girl in the preschool class. I don't know that it was distressing to her that she was saying sexual things. She didn't really understand what she was saying. She had some physiological hyperarousal going on as well, some hypersexualization from the abuse. But I don't know that she knew that this was something to be necessarily distressed about. As a sidebar, like with sexual abuse, that's something that's often really hard for people to understand. Sexuality, the physiological reaction that happens in your body is not conscious, it's not a choice, it's something that just happens. And so when kids are sexualized at a really young age, there is a cognitive and a cultural component to that, like a learned component, but some of it is physical. Think about it. Little babies in the womb have erections. It's a reflex. So there is a sexual reflex going on. So when a lot of kids are sexually abused, they aren't choosing to enjoy it, but it may still feel good. And that doesn't mean that they wanted it or they consented. So I know that's a little bit unrelated to this, but just as a side PSA. Again, the reenactment through play. And it also may be hard to determine when they're talking to you about dreams or anything like that, whether it's actually related to the traumatic event or whether, it's just a dream that they had and it seems sort of fuzzy, and maybe it's distressing, maybe it's not to them. But if you have young children or have been around them for a long time, you know that they will tell you all kind of things about what they're dreaming. My just turned 4-year-old the other day was pretending she was dead in the bath and said she was having dreams about being dead in the bath. Like, I don't know of any trauma she's been exposed to. So sometimes it's really hard to make those cognitive connections that you will with older kids. So just something to be aware of. Also, all related to this, there's a common thread here, right? They may have negative alterations in cognition, like belief systems, like people are bad, I can't trust them. They may not be able to voice that, but it just comes out through their behavior. Like they're really suddenly very shy around people. They don't want to talk to anyone new. They see old men in the store, and they don't want to go near those old men because maybe they remind them of their grandfather or something. But not necessarily alterations in mood at this age range. So affect in little bitty kids is really hard to tease apart because little kids are up and down all the time, up and down all the time. And it's much more common for young kids to have just some trouble regulating their emotions as a result of trauma rather than this kind of linear change from happy kid to really sad all the time. And again, in little kids, sadness can come out as irritability, stomach aches, headaches, etc. So just keep in mind that trauma can look differently in younger children. So my guess again is that you have data on impact. You have academic data, you have test scores, you have work samples, you can interview the teacher, you can look at their grade history, you have data on their cognitive functioning, right? You probably already gave an IQ test anyway, so you might see that come out in their test scores, though it's not diagnostic. And I would be willing to bet a lot of money that you already have a lot of behavioral data on most of the kids that are getting referred for these types of assessments. Usually referred for something like ED or OHI, which we're going to talk about how to tease that apart in the next section. But my guess overall is that you have a lot of impact data already. You probably don't have to go out and get it. What you probably don't have is hard data about exposure and symptoms. You might have exposure in the records, right? Like you already know this child has an abuse history. It's already been worked on in therapy or reported. You might have some reports from teachers about symptoms, or you might see hyperarousal or reactivity in the classroom through your observation. So now we're going to, that's RIO. We're going to look at T. What are some ways to do some testing for exposure and symptoms? A little bit about measures. So a caveat to begin, remember, we're going to talk about how to screen for trauma, not how to diagnose PTSD. That is not in our wheelhouse as evaluation professionals. We are looking at a more general definition of whether we think the child has been somewhat impacted by trauma, not whether we think they actually have PTSD. So, when I talked to Dr. Gail Sheremy and Dr. Andrea Oganowski, who have probably been to your region many times presenting about behavior and IQ testing and LD and all manner of other things because they're amazing people, they told me that they are currently recommending this one measure for any child being assessed for emotional behavioral disorder this year. And you may have a lot. This is a screener. It's called the UCLA Brief COVID-19 Screen for Child or Adolescent PTSD. Don't let PTSD scare you. Again, we're not diagnosing. It's a screener. It is a brief screener that is based on a much more comprehensive measure called the UCLA Post-Traumatic Stress Disorder Reaction Index, which is much longer and much more involved. But we're going to do this screener version, okay? Let's look at this pretty closely. So, you can hand this to a kid and have them fill it out. But depending on age and your time frame here, your schedule, and the quality of data you want to get, my suggestion would probably be to administer it more like somewhat of an interview. So if you're doing it that way, you would read this aloud to them and show that to them. I would have my copy, they would have their copy, we go through it together. So this is not a standardized instrument, it's a screening measure. So it's not like the BAS, you're not gonna mess it up if you read them items, right? That being said, there is a cutoff score, so you don't want to explain too much. If someone's sick because of COVID, like your grandma It's still a measure, so like we're not going to go into that. But I'm just saying it's not, don't be afraid of the level of like whisk, oh my God, I deviated from standardization, right? We really want to get quality information, and a lot of this information is qualitative. So this one starts, the coronavirus illness had made a lot of people very scared and worried about their own safety and health, and the safety and health of family and friends. To help me understand how you're doing with what is happening, I'm going to ask you some questions about some ways we know that people react to this kind of danger. For me to better understand your answers, I have to ask you some questions first. So this is going to get, that first section is going to be about exposure. Remember that not all of these things mean that they have trauma, but it's just potential. Like we're trying to assess here, what's the degree of exposure? What kind of exposure do they have to some COVID types of trauma? Have you or someone close to you gotten very sick or been in the hospital because of the illness? Remember, medical procedures or serious illnesses could potentially be traumatic. Have you been quarantined? That might come into play. We saw that research study earlier where kids who were quarantined in China after only about 30 days on average had really increased anxiety and depression symptoms. So, have you or someone been close to you been told of a positive test for this illness? That can be very scary for kids. I don't know about you guys, but my kids keep asking when the virus is going to go away so they can go back to their normal life, and they've both had it. And my 4-year-old had a lot of trouble understanding what that meant, and getting tested itself was extremely hard for her. Very, very hard. I also have a friend whose 3-year-old son had a nosebleed after the test and was very scared because of the way they do it. Does someone close to you work around people who might have the illness? So a lot of kids, so my in-laws are both MDs in California. Their kids are very confused because dad and mom both come home in these weird outfits every night. They have to shower before they come hug them, like they're separated for a while. It could be very confusing. Or I'm worried about mom and dad. Mom is a nurse and she's at the hospital all day, every day with these patients who are very sick. Have you or a family member had to move away from home? So maybe you had to go live with someone else. Maybe you've had some housing instability. Maybe you had economic instability because your parents lost their job. This is huge, right? This is a huge consideration. It's not just primary effects of the illness. It can also be secondary effects, just like during Harvey. It's not so much how, did lightning strike you during the storm? It's, maybe your house was affected, maybe not, but maybe your family lost their jobs. Maybe your car got ruined, so your mom couldn't go to work. And now we have this additional factor of poverty. And last one on here is about someone close to you dying from the illness, which of course could be potentially traumatic. This is a very unexpected way for a family member to die. Not to mention all the media impact of what's going on. I will note that in PTSD criteria, media only counts for adults who work as like paramedics or people who are exposed to brutal details for large parts of their day, like going through photos of deceased people, things like that. It doesn't count for kids. So while I would not recommend showing your kids hours of footage about COVID, it actually doesn't count in terms of a PTSD diagnosis for trauma. There's a special section on here about military families, which I really like, being that, my brother was in the military for a long time. The kids who have military families have some unique considerations. Possibly their parents were deployed during this time in a place where the virus was rampant. Think of all the other countries on the news where this is happening and people are really uncertain and there's a lot of anxiety. A lot of places had really rapidly rising cases, and if your parent was there deployed, you might have been really worried. What about being quarantined on a military base? That's got to feel kind of scary. And what about, this is a really tough one. What about if your, mom was overseas and couldn't come back because of the travel restrictions or because of being quarantined or having an illness? A lot of people got stuck where they were, which could be sort of traumatic for kids, right? Traumatic grief, traumatic loss. And then it just says at the bottom, has anything else happened to you guys, you or your family, because of this illness that has been very upsetting? And this is a place for them to fill in different things that might have not made it onto the form. So this is all about COVID. Let's go on to this measure and look at the symptom screen. Now there's something unique about the COVID version, and I'm going to show you the regular version of the screener that's not COVID after this. But the unique thing is that even if no item is scored yes. So even if no exposure at all, we're still going to score the rest of the symptoms. So why is that? A lot of different reasons. One, kids aren't always great reporters. Two, they might be avoiding talking about it, so they're not going to tell you about it. And, three, it could be that they're having some symptoms that they're not connecting to this event, but maybe part of it. Kids don't tend to have that like ABC linear logic that we do, like this happened, then I got sad, so therefore they're related. That's different in the other form. But because this is so widespread right now, I think we're just being extra careful. So this says, for your reactions to what's happening because of the coronavirus illness, again, even if it didn't meet any of those specific things above, which again, it might be that they just can't think of anything, but something really has happened, or from a caregiver that something happened that is not being reported here. Tell me for each problem how often it happened to you in the past 1 month. So it says use the frequency rating sheet. I'm going to show you the frequency rating sheet. It's really nice because some kids are like, well, or even adults, right? What does none or what does a little bit versus some mean? So this gives you a nice overview of like, here's a month. A little would be like a couple days. Some might be like, once or twice a week. A lot would be at least twice a week or more. And then most would be like almost every day. This gives a very nice visual for them. So what I usually do is print this out or have it on the iPad, whatever, have the child looking at that, and they point to it each time that I ask. So, or they refer to it right next to them if they're filling it out themselves. So these symptoms correspond to those categories we just looked at. Avoidance, hyperarousal or hypoarousal, negative alterations in cognition and mood, and re-experiencing or intrusion. Let's see if you can guess which category each one fits in. Trying to stay away from people, places, or things that remind you about what happened or what is still happening. Avoidance. Getting upset easily or into arguments or physical fights. Trouble concentrating or paying attention. All things we've talked about. When something reminds me of what's happening, I get very upset, afraid, or sad. So disturbing, intrusive thoughts or memories. Trouble feeling happiness or love. So that's a negative alteration in mood. Difficulty feeling positive affect. Number 6, I try not to think about or have feelings about what happened or what is still happening. So ironically, like they might not endorse any of these items, and that's really tricky too, because it's like if you're trying to avoid and pretend like nothing happened and it's not bothering you, like that's a really thin line to try to say, well, this kid is just avoiding, but he actually does have it and this kid is not. And how do you make that decision? Well, obviously it depends, but probably you have a lot more than one self-report, I hope. But that is avoidance. When something reminds me of what happened, I have strong feelings in my body, my heart beats fast, my head aches, or my stomach aches. So some of those physiological symptoms that we talked about this morning. Thoughts like not being able to trust other people, that's a negative alteration in cognition. Feeling alone even when I'm around other people, so that feeling of isolation. Having upsetting thoughts, pictures, or sounds of what happened or what is still happening come into my mind when I don't want them to. That is definitely the intrusion and re-experiencing. And then, again, difficulty going to sleep, or waking up in the middle of the night, waking up really early, difficulty falling back asleep. So that can all be related to that hyperarousal criteria. So they use the sheet, and here's your score sheet, right? So these categories all go by the DSM, right? Because this is a clinical measure, but we are recommending that you use it because it gives these nice recommendations and these cutoff scores. And it's the only one right now available for COVID specifically. But so if you look at like 10, 4, and 7, okay? 10, 4, and 7. 4, when something reminds me of what happened, I get very upset, afraid, or sad. 7, when something reminds me, I have strong feelings in my body. Or 10, I have upsetting thoughts, pictures, or sounds of what happened. So these are all intrusion or re-experiencin symptoms. Let's look at 1 and 6. Staying away from people, places, and things, and trying not to think about or have feelings about what happened. Starts with ends with avoidance. Okay, avoidance symptoms. That next one is 8, 9, and 5. Okay, 5, I have trouble feeling happiness or love. 8, I have thoughts like I'll never be able to trust other people. And 9, feeling alone when I'm around other people. These are negative alterations in cognition and mood. And last one, 2, 3, and 11. Getting upset easily or getting into arguments or physical fights. Trouble concentrating. Having trouble going to sleep. So these are all related to arousal and reactivity. So you sum each one, and then you sum the total score. And I do want you to pay attention to these categories, even though we're not diagnosing, because when you go to write it up later, as I've pointed out, you're going to look at these different categories. Also, what we talk about in part 4 today, like it might be important to know that like if the only category is arousal and reactivity, and there's nothing else, then like maybe that's ADHD and not trauma. So it is important to break it down that way. Now, what they're recommending is that 21 or higher total score means potential PTSD, like full blown, go refer this person for a full PTSD evaluation, probably as part of either your psychological services team if you're lucky to have one. I think maybe only Sci-Fair and HISD have those, but or to an external clinic. And if anyone wants, I can send you some mental health resources in the Houston area that are sliding scale or low cost for COVID for that. So if you look at this chart here, 1 to 10 is minimal PTSD symptoms, or 0 would be none, but just monitoring, providing education, maybe rescreening as you go along. 11 to 20 is that mild range, a gray area, probably further evaluation, better safe than sorry. Definitely monitoring, providing education to the family, and probably a full assessment. It says PTSD-RI, that's the full version of this measure, the reaction index, which includes a full exposure screening and many more symptoms. And then 21 plus, that's a full assessment for sure. Triage, meaning like refer this child immediately. They definitely have some things going on here that are related to PTSD. They're showing all the symptoms, and they really need PTSD-specific treatment right now. So what about for children for whom COVID is either not the whole story or not part of the story? So outside of that COVID concern, where we're recommending that COVID-specific screening measure for all kids this year, when you have kids who you think, COVID is maybe not what's going on, or even when they were referred before COVID, they had documented abuse, neglect, exposure to school shootings, those kinds of exposures. I would recommend the non-COVID version of the same exact screener. So it's a little different. I'll go over the differences, but it's the UCLA Brief Screen for Child and Adolescent Trauma and PTSD. The COVID version came out this year. I believe this version just came out last year in 2019. It is free, and at the end I'll show you a link where you can download it. You have to pretend that you're paying and then pay $0. But this is created by the same people. So with any child that you already have documented or already reported history of traumatic exposure, things that I just talked about, mostly sticking to already documented or already reported, because again, we are not CPS investigators, but cases in which you believe that trauma has a serious contribution to the child's behavior, learning, developmental problems, you may give this version. Now, you saw in the COVID version how exposure was based only on possibly traumatic events related to COVID. In this one, it's going to be, they're going to self-report an event that you don't give them a prompt for, really, besides saying, and notice it says interviewing. Okay, so ideally you're sitting down to interview this child. Sometimes people have violent or very scary or upsetting things happen to them. This could be something that happened to you or something you saw. It can include being badly hurt, someone doing something harmful to you or someone else, or a serious accident or serious illness. So in the full version, you go down a list of discrete events, like has someone slapped, punched, kicked you? Has someone touched you when you didn't want to be touched? This one is just a screener, so we're just asking a broad question. Again, mostly for kids we already have documentation, or a parent or someone reporting that there's already been something we know has gone on. Has anything like this happened to you recently? Get them to give you a brief description. Even if you already have the report, it's nice to hear what the child thinks, what their side of the story is, and it might surprise you, the things that they say versus the reports. It's not always the same version, but it's also not always the same level of importance. So you may think like sexual abuse, that's terrible, but the worst thing that ever happened to them was having to move into foster care, for example. I've seen that a lot. What about things that have happened in the past? So we're not just talking about recently, right? You're going to prompt them specifically about things in the past. If, of course, by chance something comes up that you cannot find documentation for, you're going to have to report it and go to your supervisor. You're going to have to call the child hotline to report it. The DFPS webpage has information about that. But again, in a school, we are trying to stick to things that we're not investigating. We're not trying to dig up dirt. We're trying to see what's already there. So one thing that is different about this version and about other versions of the trauma screeners are that you have to have the child choose an index traumatic event. Remember that PTSD research and criteria is based on veterans coming back from war. They choose like one event to talk about in therapy, and that's the event that all their symptoms are based on. So it kind of seems wacky to have that for kids from complex trauma backgrounds. But you do have to get them to choose which of these things that happened bothers you the most now. And again, it doesn't have to be like one incident of abuse, right? It could be like, oh, the physical abuse in general. So they have to choose this index event because when they rate symptoms, and this is almost exactly the same as the COVID symptoms checklist, they have to talk to you about the thing that's bothering them now. Because when it talks about, look at number one, I try to stay away from people, places, or things that remind me about what happened. Well, this can be very confusing for a child if you didn't define what happened. So you're asking them to predefine what happened so that the symptoms can be based on that same event. Same frequency rating sheet with this form, same symptoms that you sum up, and the same criteria here. So 21 or higher, further evaluation or referral. 0, of course, is 0. 1 to 10 is minimal. 11 to 20 mild symptoms, maybe probably for further evaluation, but definitely monitoring and education. And 21 or over, total score of 21 or more means potential PTSD. They're hitting symptoms in every category, and that might be a further referral for full evaluation. And they do recommend the full evaluation with their measure, the UCLA Reaction Index, PTSD-RI, and it is available at www.reactionindex.com. So there's the website for you, reactionindex.com. It is a private company that puts this out, and their full measures you have to pay for, but the COVID and the brief screener, at least right now, you just add it to your cart and it gets checked out, but you don't have to enter any credit card information or anything like that. I think they're just tracking who's using it and what kind of settings, and they put in there how many times you're going to use it, but you download a PDF. All right, exposure in the report. How do we write this up? Now, I'm going to tell you how to write up the blurbs for these individual measures, give you a couple examples, and then in part 4, we talk about how to actually make decisions about where this data goes. But real quick, in the report, how do you write up that the kid's been exposed to trauma? Well, for COVID, this is fairly straightforward. You want to be really specific and say, like, not just, oh, this child was exposed to COVID, because everyone was, but you're going to take specific things from that checklist. So given the fact that this child experienced difficulties related to COVID, for example, parent died, etc. If it's not related to COVID, you're going to do the same thing. You're going to be very specific. Why did you even give this measure? For COVID, you may not have to justify this. For other kids, it's given her history of physical abuse according to DFPS and school records. So I'm being very specific about how I know this. I'm not sneaking around and saying like, oh, well, I just felt like she was maybe abused and she like was acting kind of funny, so I gave this measure just for kicks, right? We don't want to overscreen. And then she was administered this UCLA measure in an interview format. This measure is, and this is where you define what it is, right? Just like your IQ test, just like your BAS, you just say, what does it do? It screens children and adolescents for exposure to potentially traumatic events. Notice the word potentially, and possible post-traumatic stress, not disorder, symptoms. Possible, potentially. We're just screening. Now, on that measure, I always say, just like the BASC, like tell them what symptoms she endorsed. Now, this is not a norm reference measure. They're not going to get standard scores from this. So you're just going to say exactly which symptoms they reported or which exposures they have reported. So in this case, this little girl reported being bitten by a snake, victim of alleged physical abuse. So I didn't mean to laugh at the snake part. It's just sometimes kids will report to you everything that's ever happened. Their grandmother died, whatever. You just report what they reported. And then at the bottom, there's that indexed event. She identified that the alleged sexual abuse as the most significant traumatic event she has experienced. So you do need to say that unless it's COVID, which the form doesn't require you to choose an index event because it's assumed that all the symptoms are about COVID. Okay, now is where you report the symptoms just as you would on a BASC. So 4 categories, the intrusion and re-experiencing. For example, having upsetting thoughts, okay? We're only putting this if the child endorsed these symptoms, obviously, and probably at the higher levels, like very often 2 or more, just like the BASC. You don't want to report something that was just sometimes or never. Avoidance, so there's an example of a symptom they endorsed, trying not to think about what happened. Negative alterations in cognition or mood. For example, this person endorsed having trouble feeling happiness or love. And hyperarousal or increased reactivity. For example, this person might have endorsed difficulty sleeping. Some people will put in there, like when they're writing the BAS, they'll say like, he often experiences this. You could put that in as well, as long as you use the wording from the scale. But I have kind of stopped doing that because I feel like it's just repeating what the scores say. Overall, the total score of 19 indicates mild symptoms of post-traumatic stress, no disorder. This is from that chart. This is directly from this chart. Scores in this range indicate that monitoring, education, and further assessment should be considered. Again, it's right there in the chart. The mild symptoms, what's the recommendation? Let me show you. See, minimal symptoms, mild symptoms, potential PTSD tells you right there what's the recommendation. Full assessment, triage, monitoring, education. So we're going to write that right in the report. We're getting it straight from that measure. And next, we're going to talk about how that fits into the FIE.